years ago told me that I could not retire from midwifery until she got pregnant. And so I did spend some time with you.
Made her come out of retirement.
Yes,
appearance.
Yeah, I even had to like put my snow tires on, you know, so I could have your baby outdoors.
Yeah,
I thought I was going to go like winter without studded tires, but it didn't work out. So anyway, I love the work that Michelle is doing, and I'm really excited to have you present about pelvic floor stuff because it's super duper important and we need to know about it. So you can talk about your other fabulous qualifications and who you are. So anyway, take it away. Yeah.
All right, thanks, Carol.
Yeah, thank you.
So just kind of as a show of hands, so I kind of know who I'm talking to, how many people right now do pelvic floor work in their practice?
Like internal?
Yeah, internal pelvic floor work. And how many people could do it because of their scope of practice?
How many people are licensed massage therapists in Oregon and don't know it's in our scope of practice? Raise your hand. Yeah.
I would like to know how to get it into our scope of practice
Yes.
in Washington.
Yeah.
Yeah, here.
Well, and that's
Yeah.
and how many people here are kind of actually interested in potentially doing this work?
That was
Great. So I'm a chiropractor by trade. My mom, who's here today, she was a nurse midwife for like 100 years. She ran a high-risk perinatalology clinic. And I swear I would never work with pregnant women. They were like always making me wait in schools and everybody else got picked up. Totally traumatized by them. Never wanted anything to do with them. And then I went on in chiropractic school. I was like, I called her one day and I was like, Mom, I totally have the bug. Like, I want to work with pregnant women. Because in my profession, we're mostly male dominated, mostly men. They don't want to work with pregnant women. They're like afraid if they adjust them, the baby's going to shoot out. And so I started treating pregnant women. And then, you know, all these mothers would bring me their babies. And I was like, I don't work on babies. And they were like, well, you're working on my baby. You birthed me when I was pregnant, and I trust you. And so that's how I met Carol. So I was like, well, I better get some training if I'm going to work with all these babies. So from there, I was working with moms and babies. In my first year in practice, I only treated moms and babies. And I kept seeing all these moms with pelvic floor issues, and I would work on their pelvis and work on the muscles and do all this good external work. And then, you know, I'd be like, look, I just need you to exercise now and you'll be fine. And they'd start crying and they'd say, I can't exercise because every time I go jogging, I'm peeing my pants, or every time I cough, and, you know, it's just horrible. Like just, you know, really poor quality of life. And so then I would refer them out to physical therapy and say, well, you know, there's treatment for this, you should go, I think it would be really helpful. And then it happened again. They were like, nope, you do it. And I was like, I don't do it. And then we learned in chiropractic school, we learned about pelvic floor work, and I did have some training in it, but I was like, I don't really do work. And they were like, I don't care, you try it. So then I was like, okay. So I went on and got trained in pelvic floor manual therapy. My main teacher was actually a man, of all people, in Portland, Dr. Brian Basinger, and I'm really grateful to him for everything I've learned. And then my patients have really taught me a lot. And so this lecture today is kind of about what is pelvic floor therapy. It's a whole big world of stuff. It's my favorite thing to talk about. My second favorite thing is autoimmunity and how gluten's going to kill all of us. I'm sure you're not sure about that. And then we're going to have some time for questions at the end. But you know, if you have a burning question, feel free to ask it. So, all right, point it at the machine. All right. So what's going on in today's healthcare situation? Most healthcare providers, and I'm speaking more about physicians, OBGYNs. I love them. I work with a lot of them, but they don't have the training to diagnose neuromusculoskeletal conditions, right? We know this. They have to spend so much time being surgeons and learning everything else that their hours of neuromusculoskeletal diagnosis are fairly low compared to what a lot of us have. So they don't necessarily have the training to identify when something definitely is coming from the neuromusculoskeletal realm in the pelvis. Doctors lack detailed knowledge of myofascial conditions, and patients then are not often appropriately referred. Even in Portland, where we're this like hotbed of like pregnancy and birth and oh, let's talk about everything, there's still a lot of people who don't know where to send their patients. And so they'll tell women, well, you know, everything checks out fine. I think it's normal. I think you're okay. And what happens is the patients give up because they're told it's fine, it's normal, well, you know, it's great. You don't have endometriosis, but I don't know where that pain's coming from. You know, or they'll say, well, you've had 3 kids, of course you pee in your pants every time you sneeze. That's normal. You know, and or people believe that it's due to age. You know, I have a lot of women who are like, well, I'm 60, and I'm like, well, so what? You know, like don't blame everything on being older. You know, sometimes it's very treatable. Or even more commonly, they think they're the only one with this problem, and it's really isolating and depressing, and you know, they just don't even talk about it. And then I'll treat like one woman, and she'll like mention something to a friend, like, well, I've had this problem for like years, and now it's better. And then like the friend's like, oh my God, I have the same thing. And you know, it's nice to just get people talking about it. That there's things that can be done for these conditions, and that people don't have to kind of tough it out anymore. So I always tell people, pelvic pain and dysfunctions is kind of a big umbrella that we're going to talk about. Under that is kind of urinary incontinence and stress incontinence. Super common. But I always tell my patients, it's not normal. So that's where I think that we all need to start educating people about that. How can we help? We can all help. I really feel like anybody who works, and I'm going to kind of keep it, men have pelvic pain, I'm not going to talk about that today, but with women and for the scope of this conference, I'm really going to kind of keep it to the pregnancy, postpartum realm of things. You know, so we all have contact with these moms in our lives and in our practice. And even if we don't do this work, just to be aware that it's out there and to be able to make appropriate referrals can make a huge impact in somebody's quality of life. So educate yourselves. Educate yourselves about what are the resources in your community, who is doing the work, you know, who can you work with, who can you send your patients to, because your patients, even if you don't ever do internal work, or maybe you just you're a lactation consultant, but just asking the mom, hey, are you having any of these issues? Hey, here are some resources. That's awesome. And as women, we just need to start talking more about it. I find that like in my mother's generation, there's a lot of women who just, when you have those problems, you dealt with it, that was part of aging, and everybody just told you that. And I find that like, you know, amongst my mom friends, that women are a lot more savvy nowadays about pelvic pain, about pelvic floor issues, about seeking help. And some of that could be, you know, the part of the country that we're in. But I do find that there's like this shift going on, which I think is pretty cool. Oops. Okay, the first step. So, education. You guys are here today. That's awesome. There's lots of good resources. Reach out to other providers, like I said. And I think it's really important to know that by the time a woman will actually seek out treatment and end up in your office, the causes are usually multifactorial, and there's a lot of stuff going on. And for that reason, I usually tell most women they need a super team. You know, you need more than just one person. And it's your job as that provider, I feel, to help them find that super team. You know, so what's going on? Hey, guess what? They had a baby, and like mom hasn't talked to dad in 6 weeks because she's pissed at him. Well, help her find a counselor. Or mom has birth trauma. Help her find a therapist. You know, oh, it also sounds like mom is like completely has, you know, Hashimoto's now and has like all these hypothyroid symptoms. Get her to, you know, a naturopath. Get her to a GYN. So help her assemble this team of people that can help her. And don't be intimidated by it. You know, you don't need to be all things for all people. But if you can figure out the part, you know, of this work that feels good to you, and then meet great people in your community who can do the other stuff, it's a really powerful thing for these women. Oh, sorry. Okay, what is pelvic floor mat therapy? What am I even talking about? It's hands-on therapy focused at balancing the muscles and ligaments and joints in the pelvis. It's comprised of internal and external work. So internal myofascial release work, external myofascial release work, mostly addressing trigger points and dysfunctional movement patterns. It's evaluation of connective tissue restrictions and neural tension, and also structural and biomechanical things in the pelvis. So, and again, you can do this work without doing all of this, right? If you're like, I don't know anything about the structural component, then find somebody else who does and send them to them too. It's okay to all work together with it. What I tend to find is that it's really good to talk to people and ask them, what does it mean by doing pelvic floor work? Because there's a lot of people who say, I do pelvic floor work. Well, what do you do? I hook my patient up to an electrode and I show them on this little dial that when they do a Kegel, the dial goes up. And if they can do some focused breathing, the dial goes down. And then I give them a dilator because their muscles are too tight. And I think that work is really effective for some people. What I'm going to talk about today is hands-on work. I don't use any tools. I don't use anything other than my hands. And I feel that what happens in the pelvis, especially during pregnancy and after childbirth, is we get these dysfunctional movement patterns set up, right? And we've all been there. Anybody who's nursed a kid, right? You walk around all day, your shoulders like up around your ears because you've been doing this, and these muscles are super tight, and these muscles are super tight, and these muscles are shut off because these guys are talking all the time, and we end up with those patterns in the pelvis. And I really feel like unless you correct that, then just using something to stretch the muscles doesn't really treat things. Maybe it symptomatically will help for a while, but I don't think it really treats things at the root level. I think you have to really kind of balance those muscles. You want balance, and that's when I think women have a really profound change in what's going on. So it's often multifactorial, like I said, many different causes: structural abnormalities, visceral dysfunction and disease, activity-related injuries, and physical trauma. So structural issues, pelvic torsion, pelvic rotation, kind of, we all heard Heather's lecture. You know, if you have these muscles that are all connected to the bottom of the pelvis and then it's really rotated, well, it's like wringing a beach towel, right? You know, all those muscles have this like twist. And then we're saying, okay, you're also responsible for urinary continence, stay working great, you know, while they're like this. Well, they don't work well. You know, it's kind of like pretty common sense. Leg length inequalities, that's a big one I see. Sometimes it's anatomical. Somebody's just born with a super short leg, and, you know, until they get pregnant and weigh 50 pounds more, they never knew it was a problem. And then, you know, after relaxing, gaining weight, and having a baby, their pelvis is like, oh, time out, you know, this isn't working for me. So that can cause pelvic pain. Sometimes, you know, it's iatrogenic. I see women who are like, you know, I never had this pelvic pain, and then I had a full knee replacement, and it's the wildest thing. Like 3 months later, my vagina hurt all the time, and I'm like, no, it's not crazy. It's related. You know, suddenly they have this discrepancy, they have this uneven foundation, and what's trying to compensate for it? All of these muscles here. So it actually makes a lot of sense. Pubic symphysis or sacroiliac joint instability. We see this all the time, right, in our practices. We see the moms with pubic bone separation. We see the hypermobile sacroiliac joints, and kind of, again, like Heather talked about, you get these patterns where the muscles are just like clamping down, trying to stabilize, and you know, a lot of tight muscles. And that will set up these pain patterns. Postural abnormalities and aberrant movement patterns, what does that mean? Just that we move differently. When women hurt, when their pelvis is hurt, they walk around like somebody kicked them in the stomach. So they walk upstairs differently, they use different muscles. They pick up their kids differently, they use different muscles because they hurt. And certain activities they know will hurt more, so they avoid those things. And then they strengthen the muscles that usually are already too strong, and they don't use the muscles that aren't working enough. And then our nervous system kind of takes that one step further. If we have a muscle that's always on, saying, I'm turned on, I'm tight, it will turn down its neighbor. So it's called reciprocal inhibition. So to contract my bicep, my nervous system knows I have to turn off this muscle. Otherwise it'd be like in this tug of war, right? To extend my arm, my tricep has to turn on this muscle, has to turn off this muscle. And you see these patterns where in the pelvic floor, these muscles are like on, and they're turning off their neighbors. And then, you know, what do? We're like, oh, just do Kegels. Oh, do more Kegels. You're not getting better. You're not doing 300 Kegels a day. Well, that doesn't help because you're just reinforcing these, you know, faulty patterns that are being perpetuated then by exercising and really like grounding them into your nervous system. And this is how you should always move. So, is this okay? Am I like getting too technical? That's what it is.
No.
Let me know.
Not for this crowd.
Yeah. Visceral dysfunction and disease, so endometriosis. So women with endometrial tissue, can we fix endometriosis with pelvic floor work? No. Can we help those women? Can we lower their pain? Can you see somebody once a month when they're having 2 days before the pain would really kick in for them and do pelvic floor work and then keep them from feeling like they have to have a hysterectomy to get rid of it? Yes, it's really effective. You know, and so again, the team, the super team, who's their GYN? And you tell them, this is what I'm going to do. I'm going to work on inflammation in the pelvic floor. I'm going to improve circulation in the pelvic floor. I'm going to make sure that there's no muscle tension in the pelvic floor before they go start their menses. They do way better and are really happy. Interstitial cystitis, urinary frequency, and stress incontinence. So a lot of bladder stuff. You have the women that tell you, I've had interstitial cystitis for like 20 years, and you know nothing can fix it. You know, can pelvic floor work necessarily fix it? No, but there's usually all of this tension in the pelvic floor. There's all these other things going on, and again, like that's a really good case for needing a whole team. Right, because now there's all this new research linking interstitial cystitis to autoimmunity and to gluten sensitivity and food allergies, and same thing with a lot of the stress incontinence, you know, and so you need to, even if you're not that person, you need to know who else to work with, so that with the team approach, you can help these women. Viscerosomatic and somatovisceral referred pain, I always think this is really fascinating. So pain from the organs can manifest as muscle pain, sorry typos, I'm a horrible speller, so I'm sure there's a couple in here. And muscle pain can manifest as visceral pain. So what does that mean? So the most common example is when people are like, I know I was having a heart attack and the only thing that hurt was my left arm, right? Pain from the chest, your brain and your nervous system perceive it as left arm pain. People who go into chiropractor's office, my right shoulder is killing me. There's like absolutely nothing wrong with their shoulder, but you palpate their gallbladder and they fly off the table because they're actually having gallstones. So that's just the way that we're wired, and that I could like talk a whole nother lecture on that. But sometimes what will happen is the viscera are really irritated. So you have this uterus with fibroids and cysts, and it doesn't manifest as any sort of normal symptom that you would expect to see with cysts and fibroids, but they have horrible pelvic pain or they pain with intercourse, or you know, they'll just say things just don't feel right, like something is wrong with me. And vice versa. Sometimes women will have, you know, these really painful trigger points in their pelvic floor muscles that will feel like menstrual cramps, or they'll feel like ovarian pain. And so it's a big like sea of nerves down there. So that's also something that's really fascinating. Hormonal changes, perimenopausal women, postpartum. Those things can all influence, you know, edema in our bodies and, you know, just what's going on, and can have a big effect on them. Underlying autoimmunity, this is a big one. So when you're talking to women and they're like, first of all, it takes you like an hour and a half to get a history out of them because they can't remember anything. And they're like, oh, I have to drive around with like Post-it notes on my steering wheel. And they tell you they've got fibromyalgia, and like, oh, they thought I had rheumatoid arthritis, but I didn't, but I don't have a thyroid gland, I'm not sure why, I think I had some like Hashi something. So, you know, those women that are autoimmune all have pelvic floor stuff. And in the research, I don't know why, but I think it's a combination of, you know, some of the dietary gluten links that we find with like the bladder and bowel irritation, but also too, their guts are on fire, and the like inflammation in the intestines can often manifest as pelvic pain. So that's really fascinating. Chronic constipation, IBS, again, same type of thing. I usually tell people, I can't fix your IBS, I can't fix your constipation, but let's work on the pelvic floor muscles and see what happens with all of that stuff, and it usually gets better. Or improved. You know, even if it doesn't resolve, it'll improve. So. Okay, activity-related causes. Prolonged sitting, like airline pilots. Oh, it's all food. No, not everybody, but anybody who has to just sit all day. Frequent positional changes, like police officers, they're sitting, wearing these heavy belts, and they have to get out of the car really fast and go do something. A lot of them have like pelvic floor trauma, plus they're like wearing all the, you know, all their gear. Midwives, a lot of midwives, always in crazy positions for a long time, moving around. Overtraining, I call them the marathon mamas. They're like, oh, I've got pelvic floor pain or pain with intercourse, or they come in because they're like, well, I'm leaking urine when I'm jogging. Well, what are you doing for jogging? Oh, I'm training for a marathon. Oh, do you have any kids? Yeah, I've got like a 2-year-old and a 4-year-old. Do you take them running with you? Yeah, it's pretty hilly here. Where do you run? Oh, back in the hills. So I'm like, cool. So you're running like 12 miles a day, pushing like 60 to 70 pounds, and you think it's like weird that you're peeing in your pants, and that doesn't even work anymore, so you just like pee the whole time you're running, and that's normal. And and I never like take away somebody's sanity, so I never tell people to stop running. But I'm like, okay, so if you have to push like both kids in the stroller, how about you run on a flat surface for like 5 miles, So work with them. But those are things that you'll see a lot. Overstretching. So the people, like Heather was saying, the people who are kind of like have to do their yoga because that's the only way they can get a deep stretch. There's a lot of pelvic floor issues because sometimes those pelvic floor muscles, I think, are trying to stabilize. And it kind of sets up this pattern where people feel like they need to really stretch because there's this tension and there's not a balance. And our body really wants to move towards balance. Heavy lifting with poor posture, or people overdoing it at the gym with poor form, that type of thing can be a cause of pelvic floor. And when I say pain, I also mean dysfunction, so just kind of this weird something's not right down here. Activities such as like horseback riding, cycling, for some people, that can really irritate them. Traumatic causes of pelvic pain and dysfunction. Birth, hey. Even vaginal deliveries, especially I think those really fast deliveries, or really prolonged pushing, or pushing when mom has an epidural and maybe her legs are in this crazy position that she can't even feel that she probably shouldn't be in this position, and she's pushing like that for 4 hours. And then, afterwards they've got this baby to take care of, they're recovering from birth, and what happens? They go to their 6-week visit. They're like, oh, you're fine, you can have sex again. And they're like, oh my God, it's like the last thing on their mind, right? And they're like, every time I cough or sneeze, like I'm peeing my pants though. And the other providers are like, oh, that's normal, that'll go away. And at 6 weeks, like it kind of sometimes still can be normal, but definitely by 8 weeks, it shouldn't be there. 12 weeks, no. And then I see them when they're 6 months postpartum. And it's been going on, but they don't know who to go to because the last person who, they had this great relationship with their well-woman care told them it was normal. So they don't want to go back and be like, well, you told me it was fine, but, it's kind of affecting my quality of life now. So they don't really know where to go, and they don't know what to do. And I'm going to talk about this over and over, but I really think that, educating these women at that 6-week visit to say, this can still be a little normal right now, but you know what, if that doesn't go away in another couple weeks, give me a call. Or if it doesn't go away and you can't get your act together to call me, just know, even if it's a year from now, there's stuff you can do. And you can call me and I will get you to the right resources. So just to plant that seed, I don't really like, I think like new moms, having been a recent one, I think they have like so many things on their plate already that I never give them this window of like there's this golden time to fix your pelvic floor, and if you don't do it, you're setting yourself behind. They're already worried about like their milk supply and going back to work, and so I usually say that they kind of end up in my office 6 to 8 months postpartum. So just long enough to have gone back to work, realize it's really hard to work and have a baby, and then they decide, well, if I can just take care of myself a little more, because I haven't taken care of myself in a while, things will be better. And that's when they start finding that as they're more active, they're having some pelvic floor issues, and they don't really know what to do. Cesarean births, that is, we'll talk about tearing and episiotomies. That can be a really direct cause of pelvic pain. A lot of times you'll hear moms say, like, oh, I just feel like I have a pebble in my underwear. Every time I, do yoga or dance, like there's just this weird thing there. Or they'll say, I had some tearing and now I feel like I have this like dead zone in my vagina, but I'm fine. So, I don't know what that's all about. Well, yeah, they do. They call it the dead zone. So, I want to talk to Eve Ensler because I have like so many funny like vagina anecdotes from my patients. What they say, yeah. If I had $1 for every time a woman said, I should have listened to my vagina, they never liked that guy, but I was wet. I hear that all the time. My ex-husband, and my vagina never liked him. It's so funny. I know, it's really funny. I hear it, I'm like, really? So, some scar tissue that needs to be addressed. It can be a little tough and fibrous, and that's a really great indication for pelvic floor work. Cesarean birth, scarring, and adhesions. So sometimes with these women, even if you don't do internal work and that's never your intention, just get the scar moving, get the adhesions gone, get the fascia happy again. And that's our realm is, doing cranial work, right? We're really good at that stuff. So even just doing that can fix a lot. Accidents, slip and fall on your tailbone, car accidents. And another thing that happens too is women will get pregnant and then they'll remember that they broke their tailbone like 5 years before, and they're terrified. They're like, how am I going to push a baby? And then they remember that they had to like sit on a donut for a year and like it's horrible, but they've kind of like forgotten about it until they realize that they actually have to like move a human through there, and then they freak out. And so that's another good time, I think, to do pelvic floor work. Or moms get pregnant and they have pelvic pain suddenly. Good, do pelvic floor work on them and call their provider who's managing their pregnancy and just say, I do pelvic floor work, your patient's having pelvic pain, what do you think about me working on them? And they're like, great, please, like do it, they want you to. And I always tell my patients, there's like no eject button, right? So it's not like you're gonna like run across something in there and the baby's gonna shoot out, and of course there's obvious contraindications, like somebody has a low-lying placenta or uterine irritability, there's times when you wouldn't do the work, but in healthy mom, healthy pregnancy with the provider's go ahead, it's really empowering for these patients. I had a mom who, this kind of goes into the next section too, this with scar tissue. She was burned severely as a child. She had skin grafts from the knee down and, was missing a couple toes and had really deep pitting burns the rest of her upper extremity around her pelvis. And she got pregnant and she had had this horrible pelvic pain, like for most of her adult life, and she was really stressed out about giving birth, and she didn't know she should have a planned C-section even because of it. And so, I worked with her for like weeks on just the scar tissue in her legs, and her pelvic pain went down by 60%. I didn't even touch her pelvic floor, but just actually getting that whole kinetic chain moving had this profound effect, because I always think about it, if somebody downstream isn't doing their whole job, somebody upstream has to work harder. And it usually like ends up in the pelvis. I see all the time the pelvic floor muscles are like trying to do the job that the rest of the body isn't. So if somebody's feet aren't moving properly, they don't have enough flexion and extension, well, what's compensating for it? The knees, the hips, the pelvic floor muscles have to balance and deal with all that proprioceptive input. So that's really common. Also scarring, like ruptured appendix. You see these women who are like, I can't get pregnant, they don't know why, but my appendix ruptured, and they said sometimes women have scar tissue from that, and there's nothing else wrong with me. It can be really great to do scar work and work on their abdomen. Work on women who've had hysterectomies, work on their abdomen, work on the scars, just cranial work. I mean, really like basic work before the pelvic floor work can be, altogether really transformative. Surgery itself, hip replacement, those women need pelvic floor work. Anybody who's had a hip replacement. Anybody who's gonna have a hip replacement needs pelvic floor work. And I've seen people be able to delay their surgery by a couple of years because you can keep the muscles moving well, and it will prolong the life of that joint, or at least improve that person's function and mobility. Dr. Basinger had a patient who the orthopedic surgeon swore that wasn't her x-ray, because he's like, people with hips this bad don't move like you. And she needed surgery, but he's like, I'm not going to do it on you for another year. He's like, and her hip looked horrible. I mean, you can see the x-ray, you'd run screaming from the room, but she was pain-free and she had good function and good mobility. So the surgeon was like, well, it's not really indicated. So that can be really, really helpful. And then abuse, physical abuse, sexual, emotional abuse. No resources in your area of who to send those women to. I feel like my realm is as a provider, is like the tissue and the fascia and the musculoskeletal stuff. And what I tell women before I work with them is, hey, if you have any of these abuse issues in your background, this can come up during this work, but I'm not the person best suited to help you through that, because that's not my area of expertise. And for some of you, I'm sure you have a hand in both worlds, but I don't. And so I tell them, listen, and especially if like they get that look that I know there's something there, they'll say, yeah, that's an issue for me. I say, I just want you to have something in place before we start the work. So if something does come up and you need some help, that you know who to go to and you've already established that relationship, because I don't want you feeling like you're freaking out and not know who to turn to. You know, I don't feel that's responsible of me as a provider, you know, to just say, well, let's just see what happens. So I think that that's really important. And then I also follow that and tell them that, you know, when they come in to see me, this is a space for them to work on the physical, that they don't have to go there if they don't want to. You know, I don't put it on my shoulder patients that have, you know, disc herniations in their neck and shoulder pain because they hate their job and they hate their desk and they hate their boss. I don't make them lay there on the table and relive all of that hate that they have while fixing their shoulder. I don't think it's a prerequisite for it. And I don't think it has to be a prerequisite for treating pelvic pain. I think that it's very intertwined. I think there's stuff that people need to deal with for sure. But I tell them this is a space where you can come in and feel better physically. And what my patients say, who do have a lot of abuse in their backgrounds, is that they appreciate that. And there's no one right fit for everybody, right? This is just my own opinion. But they really like that. And they're like, thank you, because for me, my therapy is running, and now I can run again. And, you know, I don't have to, like, come in and to dread these visits, like, oh God, I can talk about it, or bring it up, or, you know, even mentally go there. They can kind of choose what works for them. So, you know, and you just have to find in your own practice what works best for you. But that's how I kind of handle it. And you know, even with having those good boundaries, that it always comes up. You're always dealing with it, right, on a daily basis. So again, just knowing resources in your area, in your community. Let's see, common presentations of pain and dysfunction. So this is what people come into you labeled with. Itises, inias, and syndromes, right? It means we don't know what's going on. Coccydynia, that really just means that they have pain in their tailbone, but we don't really know what's causing it. Dyspareunia, they're having pain with intercourse. We have a lot of good ideas about, you know, where it's coming from, what could be going on, but really, it's kind of, these are all kind of what I call garbage can diagnoses. It means like the patient doesn't have anything else that we can run a lab for and test for. Some of these are more like easier to validate, but a lot of it is that we've kind of like created like diagnosing fibromyalgia. We sort of have this like set of criteria that if all of this is going on, then yes, you have it. But what does that mean, right? It still means at the end of the day, the person feels horrible. And that's how I kind of feel about a lot of these things. So vulvodynia, pain in and around the vaginal area. Levator ani syndrome. This is pain usually around the rectal area, sometimes in the whole pelvis, that can be caused by spasm of the levator ani muscle. But again, people just kind of get like slapped with this diagnosis when the organs are okay. They're like, I think you have levator ani syndrome. And the patient's like, okay, what do I do about it? We're like, well, we don't, you know, we can like give you pain drugs. You know, that's usually what's going on. If you start doing a lot of this work, it will not be uncommon to have people coming in all the time on antidepressants, gabapentin, morphine. I mean, like the big heavy hitters that they take daily for their pain all the time. And I have also at least been told by one provider that it's all in their head and that, you know, it's just a mental thing because all the tests are fine. So just like brace yourselves for that, because you're going to be pretty wowed at what people will tell you. Interstitial cystitis, we kind of talked about that earlier. That's a lot of kind of a combination of pain with urination, pressure in the pelvis, urinary frequency. That is like not, you know, that's a really, that has some strict things for how to diagnose it, but people will come in with that. Pudendal neuralgia, this is the garbage can diagnosis of the pelvic pain world, right? So your pudendal nerve is the big nerve that kind of comes in the back of the pelvis and innervates a lot of the tissues. And when people have pelvic pain, they say, oh, you have pudendal neuralgia. So we can go in and either cut open the tunnel that nerve goes through, or we can inject it, and you know, and then we'll give you drugs for the pain. And so usually, what will happen is first they'll inject the nerve. They'll do a nerve block, and they'll say, well, let's do this. Let's inject it. Let's numb up the nerve. And then the person's like, I still have pelvic pain, and they're like, well, let's do it again. Okay. So they inject it again. The person's like, yep, I still have the same pain. Well, you know, I think we should do surgery and just cut into the fascial canal. It's called Alcock's canal, where that nerve, kind of the big chunk of the nerve, the tree of the nerve is going into the pelvis before it kind of roots out. Let's just cut that open. And they're, hey, still having pelvic pain. maybe it wasn't that nerve, right? Maybe it's trigger points in the pelvic floor. Maybe it's not the nerve, maybe it's other stuff going on. So that's really common. You know, the Mayo Clinic said I was okay. I'm like, well, you're still in my office because you hurt though. So, you know, it's not okay for you. So let's keep figuring it out. Pelvic organ prolapse can cause another, it's another really common source of pelvic pain, really common, you know, after childbirth and delivery. I could like talk again for like an hour on just this stuff, but cystoceles, rectoceles, uterine prolapse. So when there's basically, our pelvic floor is like this foundation for us. It kind of supports all these organs, and when the muscles get weak and stretched out, sometimes, you know, everything shifts where it shouldn't. Fascia gets stretched out, the fascia can tear, and you'll have, you know, like in the case of the cystocele, you have kind of the bladder coming down into the front of the vaginal wall. So women will say, like, I've got this like weird thing in my vagina now, like I have this weird soft bulge, I don't know what's going on. A rectocele is when it's happening with the rectal tissues coming from the back into the vaginal wall, or uterine prolapse where the actual uterus is heading south. And a lot of times, working on the muscles of the pelvic floor, balancing them, strengthening them, getting them moving appropriately and talking together can have a profound effect on these people, can take them from being symptomatic to asymptomatic. Sometimes people still need surgery or still need a repair, but I always feel like then you know that they're going into it with strong muscles and not a lot of fascial restrictions and adhesions, so I would imagine that they would have a better long-term outcome from the surgery, you know, rather than just jumping right to it. So what's going on? Again, causes are multifactorial, that's why they need a team. I've kind of talked about some of this already, but the physiological causes, you know, abuse, childbirth trauma, chronicity. I mean, just for some people, they'll tell you, they're like, you're the 10th doctor I've seen, and by then I'm like, uh-oh, you know, something's been wrong. And it's not that they've had bad care, like that's what I really want to emphasize. It's that the community that they've been in, which is usually more allopathic, MD focused, there's all these like specialists, and because with musculoskeletal pelvic pain, they don't really fit in any of the specialist boxes, right? Gastroenterologist is like, well, I don't think you have celiac disease, you know, because you have all this abdominal bloating and pain, and you know, and then like the GYN is like, well, it's not cysts, it's not endometriosis, yeah, you definitely have pain, but they just don't know like where to send them from there, or maybe they tried physical therapy, but it was, you know, biofeedback, which didn't really work for that patient. So it's not, I'm not bad-mouthing other providers. It's that there's this huge like piece of the pie when it comes to the pelvis that isn't getting met, you know, and that's why I like talking about this stuff, because I feel like we just need to say, you're doing great work, but that work isn't always appropriate, or that work is appropriate, but then there's other steps that aren't appropriate and are more appropriate. And let's help find those, you know, people and get women to them. Pathology, they have ovarian cyst or endometriosis. Hormonal, my naturopath friends and I who like treat a lot of postpartum moms, we joke about like the wheels falling off the bus, right? We've all seen these moms, they're like 6 to 1 year month postpartum, and they're like, oh, like it's like they're like so impressed that they even like made it to their appointment. Or maybe it's like the second appointment because they like forgot about the first appointment, but now they're in your office, right? And it's like their hormones are a mess, you know? You can't fix that with pelvic floor work, but you can send them to somebody who can fix their hormones and then do some pelvic floor work, and the two go together really nicely. You know, the women who are like, I've got 3 kids and I've been breastfeeding for like 7 years straight. It's like, you have no estrogen left in your body. Like, that definitely will affect your pelvic floor. When you start doing, you know, when you start doing more and more of these exams and you just start seeing more and more tissues, you know, you'll see people who have like vaginal atrophy, and they have like, the skin looks really friable, it doesn't look plump and like viable and full of life. It's just kind of like sad and thin, and there's really sparse pubic hair. And I'll just say to those women, like, you know, if your tissues kind of always look like this, and they're like, no, my vagina's disappearing, I don't know what's going on. You know, so they're aware of it, they just look like they're going crazy. And so that's definitely, you know, that's another like just really easy to see kind of physical, like, hey, there's probably a hormonal component to this, you know. Let's get you to somebody who can also address it, talk about it, and figure out what's going on. And musculoskeletal, you know, what are the muscles and the fascia doing? Again, I really think from the toes up to the belly button, but especially in the pelvis. So after all of this, now they're probably scared you from ever wanting to do the work. Don't be intimidated. You don't have to be all things for all people. You know, figure out like what you can do in your realm, in your practice, and do it. And then find other people. I think that other providers have a really great, we're really well poised to do this work and help women because we see them a lot more frequently, and we have these relationships over years, and like the postpartum mom, like they're not really seeing their GYN in 6 months, 8 months of your postpartum, right? But they're seeing us because they've been coming in because they hurt. And so we have this like rapport that we've built with them, you know, to start saying, or like if you're asking, you're getting any exercise, and they're like totally beating around the bush as to why, like just ask them. You know, it's really common after birth to have pelvic pain, or, you know, I remember you said you had an episiotomy, like, is it everything okay down there? You know, are you having pain with intercourse? You ask them, and then we'll like start crying and just be like, oh, you know, let me tell you what's really happening. And you know, and get them some help. And then during the first year postpartum, moms are, you know, often discharged. We kind of talk about this. They don't know what to do. So, I think I skipped one here. Okay, so I'm just going to kind of go over some of the muscles of the pelvic floor, right? Here is kind of, there's a lot of different layers to the muscles, so it's really hard to kind of show you one big picture with everything. But what I want you to kind of, as we're talking here, this is sort of how I think through it. Muscles can be too tight, right? Hypertonic, kind of high tone, or like this all the time. They can be turned off, right? Maybe their neighbor, their opposite muscle is like on, well the nervous system's telling its reciprocal neighbor, turn off, because we're working. We don't need you fighting us. So they can be kind of low tone, inhibited, hypotonic, all words we know. Or it's all happening at the same time, this mixed tone. And this is why Kegels aren't the answer for every woman. You know, when you have this like mixed tone or this high tone pelvic floor, so you have all these muscles that are so tight and short, they're not going anywhere. And you tell somebody to do a Kegel and they're like, I'm doing them, nothing's getting better. Well, it's because like this muscle is on and you're telling it to tighten and there's nowhere for it to even go because it's turned on all the time. So you need balance. You need balance. And I'll talk about this even more getting into the Kegels as I get into the treatment section. So some of our main muscles coming down are iliacus, so we all know that kind of in conjunction with the psoas. Don't forget too, you've also got psoas coming down here. We've got our piriformis in the back. I don't really like this diagram that much because it kind of makes the piriformis look puny. Inside the pelvic floor, piriformis is like this wide before it starts exiting through the back of the pelvis to reach the legs. So we always think like, oh, piriformis work, I'm going to work on your glutes. That piriformis internally is like this big and it's thick. It's like a really thick, big, huge muscle. And so women with like, and men too, like some of these people with like chronic back pain, chronic tailbone pain, there are these huge trigger points in their piriformis and they're like, but I've had my piriformis worked on. And you're like, well, but coming off the sacrum, internally nobody's worked on it, and you'll palpate it and they're like, oh my god, that's my pain, and you're like, well, it's the trigger point, you know, let's just work on the trigger point. You also have coccygeus, so this is a big muscle that kind of comes off the back of the iliac spine with some fascia and goes into the back of the sacrum. Obturator internus, this is one of my favorite muscles in the body. It kind of lines the bottom of the pelvis in the front of it, and then it heads backwards. So it kind of starts off the bottom of your pubic rami here, and heads backwards out to the pelvis and out to the hip. And it's kind of like a fine tuning of the hip. It does some cool motions, like if you flex your leg, it moves your hip that way. If you extend your leg, it moves your hip the other way. But that is a huge culprit, and in every diagram I see, it always ends so neat and clean right here. Well, it doesn't. It actually, it stretches out. The fibers are really continuous with everything right around the urethra. So a lot of time women with stress incontinence and urge incontinence, they'll have these huge trigger points right at that musculotendinous junction and the insertion of the obturator internus. And working on those trigger points not only will usually recreate a lot of familiar pain, but also help with the incontinence and if not make it go away altogether. And then we have this whole sling, they call it the levator muscles. It's a whole sling of muscles that kind of arise off of fascia in the pelvis in the front of the pubic bone and, make a loop. So out and around the rectal tissue, out and around the vaginal tissue, out and around the urethra. And those are all big key players. So some of the main culprits, as I like to call them. Piriformis, as we talked about. That's a big one that can really have a lot of impact dysfunction in people and have a lot of pain. Coccygeus, so anybody with tailbone pain, you have to palpate their coccygeus muscle. And then a lot of people, you can reach it vaginally. If you can't, you have to reach it rectally. And you just tell people what you're going to do and why, and they're okay with it because you're usually like their last stop. They're like, I don't care, just do whatever you need to. Obturator internus, so it originates on the medial surface of the obturator membrane, that's right here in the fascia, and then exits posteriorly into the back of the head. Always evaluate this muscle with pelvic pain and incontinence issues. And there's some cool release stuff you can do without even working internally that I can show people if they're interested in later. And then again, iliococcygeus, so that's kind of this muscle right here, pubococcygeus, which is coming from the pubic bone back to they kind of talk about where pubococcygeus, where's it going? Pubic bone to the coccyx, so here to here. Puborectalis coming here, going around the rectal tissue and back. And we got your external muscles as well. So this is kind of bird's eye, looking into a pelvis, some of the superficial muscles. This isn't, sorry, kind of hard to read. This right here is ischiocavernous. This is a thin muscle that runs kind of from the sits bone to the tip of the pubic bone in women. And it's kind of right on the inside of the vaginal opening. So if women tell you that they have a lot of pain with intercourse, but it's like with insertion, or they can't wear a tampon, or they have burning clitoral pain, that's another kind of clinical key factor because this muscle inserts on the same fascia as the clitoris. This muscle is usually really hypertonic. It needs to be addressed, and it'll be really sensitive. But when you work on it, it'll reproduce their familiar pain, and then it will go away if you can treat the muscle. Bulbospongiosis, these have the funniest names, don't they? Superficial transverse perineal muscles. So those are kind of right here in these muscles. These are usually involved and implicated with like first and second degree perineal tears. So I would say the external muscles I find are more important to treat and more of a cause of pain when there's like more of a mechanism to the injury. When it's like birth or like they fell or they've been cycling a lot. So that's kind of just a clue I hear in the history that makes me think more external than internal. And then again, like burning pain, things like that. But again, if somebody's telling you they have burning pain, you need to also work with somebody to make sure that's not a UTI and figure that out. But don't forget the viscera, right? So on top of all of those muscles, we now have all this stuff sitting on top of it. And really, the muscles underneath, let's see if I can do this, this big pelvis here is what's supporting all of it. And the main thing that I really like to talk about is that it's not really a bowl, right? We always talk about the pelvic bowl, pelvic floor bowl, it's a bowl that holds everything. It's not, it's like a trampoline. It's alive, it's dynamic, it actually moves. Every breath we take in, pelvic floor muscles should elevate slightly. And, kind of lift as we draw in our transverse abdominis and our diaphragm comes down, it should kind of lift. And it shouldn't be a saggy bowl. And so that's what, this is kind of showing. If you just do these, deep abdominal breathing and bearing down, then yes, these muscles stretch out. But really, in real life, it's a lot more dynamic than that. And a lot of like the netters and, even like if you get online with the plastic pelvis models, it's this like bowl, like this big, like hollowed out thing. It's not. And if you start just, working in there and, for like midwives, people, your hands are, in pelvic tissues all the time. You feel these muscles, they're almost a little convex, they're there, they're working. They're not just sitting there hanging out. So here's again, example of pelvic floor kind of connecting from pubic bone to the coccyx. So all the coccyx, those levator muscles that I was saying that form all these slings. You have the urethra coming down through them, the uterus and the vagina, the vagina coming down through it, the rectal opening coming down. So you know, again, this picture I don't really like because it shows it like this big dip, but it's really like, it's alive, it's moving. And that's why strengthening those muscles can help so much with things like prolapse and cystoceles, you know, because we're getting that foundation working again. So assessment, how do we figure this all out? Where do we start, right? What are the symptoms? A great history really with pelvic floor fixation and pelvic pain. It's all in the history. So you really have to like make time in your day to take a really thorough history. You know, stress incontinence, urge incontinence. So you ask them if they tell you, I pee my pants all the time. Well, when do you? Do you have to go to the bathroom? And then if you don't go right that second, you know, you lose it? Or is it, you know, if you cough, or is it, you know, when is it happening? Pain with intercourse, ask them. Is it pain with movement? Is it pain with insertion? Is it, you know, just kind of dig a little deeper. Don't be afraid to ask those questions. Pelvic pain, they say, well, I've had vaginismus. Like, well, what does that mean for you? When people come in and have diagnosed themselves off the internet, or they've been diagnosed, like, well, what does that mean for you? What does this pain feel like to you? And they'll be like, they'll think I'm crazy, but I get this like tingling out here, and then it wraps around, and then it shoots into my labia, and you're like, okay, no, that's right, that's good, that's, you know, that's all valid. Prolapse, are they having defecation difficulty? You know, somebody tells you like, I just can't, you know, this weird bulge, and I can't have a bowel movement anymore. You know, that's like an indication that maybe you have a rectocele, and then, you know, if you don't feel comfortable from the history and exam deciding if that's what it is, then send them to somebody who can figure that out. You don't have to do it all. When and how did it start? So in the, you know, of course, case of this class, birth history, types of delivery, number of pregnancies, did they have tearing, episiotomy, laceration, stitches? Did they have a cesarean birth? Was there forceps used? Was there a vacuum used? You know, how do they feel afterwards? Kind of just all of those things. Traumatic events and accidents. You know, did you have any? Did you ever break your tailbone as a kid? Exercise routines. Again, like with the marathon mamas, like, you know, like, oh, I run. Well, what do you mean? Oh, and how does that affect your pelvic pain? Because people will tell you some crazy stuff. You know, I trained for a marathon, and, you know, I had one woman with fecal incontinence, and she would have to stop and have bowel movement in the woods about 3 times every run. And she had complete urinary incontinence, but she didn't care. She just peed down her legs the whole time she was running. That actually didn't really bug her. It was the fecal incontinence that got her in. You know, so you need to ask these questions so you have a sense of like, where are we starting and where are we going with this? You know, and watch out for the people who are like, I'm just so mellow, and I just don't know why this is happening. And they're like, I'm doing an Ironman next month. It's like, you know, yeah. Other systemic issues, hypothyroidism. There's a huge link between hypothyroidism and urinary issues. A lot of it just deals with muscle tone, muscle function, menopause, food allergies, all these types of things you got to ask them. Abuse history, prior surgeries, you know, even really old surgeries, laparoscopic surgeries, hysterectomies, you know, you name it. And then are they having any other pelvic issues? You know, sometimes they'll like come see you, they're like, oh, I just have this like pelvic pain with intercourse, and, you know, and you're like, okay, anything else going on? And they're like, oh, I pee in my pants every time I cough, but that's not why I'm here. You know, so ask, because you'll be amazed what people think is normal, you know, and what they've learned to live with over years. So if you ask them, you know, what else is going on? You'll be like amazed. You're like, that didn't bother you, you know, like, so. So the second part of assessment, bony anatomy to consider. Bones and joints, are they too mobile? Are they restricted? Are they, you know, not moving enough? You look at all the vertebrae. I really like to look at the thoracic vertebrae down. That's my chiropractic side of me coming out. The sacrum, the coccyx, the ilium, what are they doing? The femurs. And then the joints, look at the vertebral discs, vertebral facets, sacroiliac joints, pubic symphysis, all lower extremity stuff. So you'll see somebody who's just, you know, like whole hip is not moving, and they have all this pelvic pain. Sometimes just getting their hip moving, stuff will go away. So the third part of assessment, skin, fascia, muscles, this is our realm, right? But toes to the umbilicus, you really have to look at the entire kinetic chain. Sometimes I will do nothing but skin rolling on somebody for 3 or 4 visits from their knees to their belly button. Like these women that have vulvodynia and like like can't wear, like, you know, their underwear hurts them all the time, like they're so hypersensitive. Their nervous system has these like, you know, these weird sensory perceptions of what's going on, and then you just like feel their leg, right? And like you'll like just roll the skin on their leg and like you see their whole abdomen moving, right? And you're like, well, that shouldn't happen. Like I should be able to just like, you know, move your leg a little bit, not have like your whole body so restricted that you're all moving. So that's something that's like a quick and easy test. Or if you're looking at somebody's tummy, like just tap their tummy, right? And if you see this like fluid ripple of like, they're so edematous, right, that they're just like full of fluid, start there. And so I look for scars. Oh my goodness, people will forget in the history to tell you stuff. What's this scar from? Oh, my bladder's tied in my right psoas. I will never forget that lady. I'm like, any surgeries? No, you know, like anything else I need to know. And I go to work on her psoas, and she's like, oh, yeah, my bladder's tied to that muscle. I'm like, thanks. Like, before, you know, I'm like poking you in the bladder. So look for scars, ask about scars. People will totally, you know, like, oh, they're here for pelvic pain and you're evaluating their lower extremity. Hey, what's going on here down at your knee? Oh, I had my knee replaced 10 years ago. That's important, but they forget, you know, it's okay. But ask. And again, that goes back to the history. Like, you really need to take a good history. So edema, tone, you know, just does it look just floppy and weak, like the whole lower limb, texture, integrity, atrophy. So that's where, when you're actually looking like at the inner thigh skin, at the skin of the, you know, over the pubic mons and the labia majora, you know, is that skin all mottled? Is it a really different color? Color doesn't always one color doesn't always mean like the same thing in people. But you'll just get a sense the more you do this work of kind of like what's normal. You know, or you'll see people with pain, and then you look at the vaginal tissues, and right over the area they're telling you they have pain, they'll have such poor blood flow in one part of their vaginal area that it'll be white, and everything around is like this pelvic purple red tissue. And I'm sure you've seen this. Like if you think about, you know, people that you've examined them before, you're like, oh, I thought that was weird, you know. And then you'll work on that area and kind of like see life return to it. Focal restriction, so, you know, it's just one area not moving. Is it a regional thing? Has this person been in pain for so long that they have like abdominal contracture and like they can't even stand up if they want to because they're just so adhered fascially? You know, what's going on in kinetic chain restrictions. So the fourth part of my assessment is kind of all the external tissues. So first I look at, you know, stem to stern, just kind of skin, joints, legs. And then you move into the general assessment. And I tell people too that you don't have to have a GYN table to do this work. I'm kind of jumping the gun, I have a slide on this, but I work on my chiropractic table, I drape it, I just have somebody lay on their back, I'm like, okay, you're gonna turn one leg out like a frog, and you know, we're just gonna do the work. So you don't have to have like a bunch of specialized stuff, and I think that's nice because it kind of like separates this from like a GYN exam. And kind of sets the tone that this is a different thing going on. So pubic mons, so just palpate the pubic area. You know, is it boggy? Is it painful? Is it tender? Usually you'll find it's like more tender on one side. That usually means that obturator internus on that side is really tight. It's just the area around the clitoris. Do those tissues look healthy? Are they white? Is there blood flow there? You know, if we're like those women who say they've got burning clitoral pain, you know, usually you'll see like on the side where they have that hypertonic muscle running along the inside of the pubic rami, there'll be slight color discrepancies, like from that side of the top of the clitoral area to the other. Labia majora, labia minora, you know, do those tissues look normal? The urethral opening, the introitus, which I didn't label because they're labeled there. The perineum, you know, especially in a mom that's given birth, like sometimes they'll have these kind of like zones where things are sort of inhibited in the pelvic floor muscles, so they'll have kind of these dips of area in the tissue where things are kind of turned off. They might have some scarring or tearing. Rectal sphincter, the tone of it. And then ischial fat pad, this gets left out all the time, and I don't know why. So under your sits bones, we've got these little fat pads, which is like a brilliant design, right? Because we sit on them all the time. So you've got this little fat pad in there, and squeeze it. And like you get in the meat of someone's butt and you squeeze it. And I tell them what I'm going to do. but you'll feel that the one side will be like gritty and boggy and painful to them, and that tells you they have something going on in the pelvic floor on that side. And you really got to get in there right off the bone and give it a squeeze. And then, and I'll be like, do you feel this? Like, do you feel how there's like, feels like there's like rice in here and like all sorts of crazy stuff. And then you feel the other side, and it'll feel like on the unaffected side, kind of smooth and like that, but like nothing special, and it's pretty interesting. That's just kind of a good pearl you can take from the external exam to kind of know what you're heading into with the internal exam. Okay, internal exam. Begin with good communication. So I explained to them there's a lot of hands-on contact time. Obtain good written informed consent, and that, I tell them this isn't a GYN exam. This is not like a get in, get out exam where like we're gonna spend like 15, 20 minutes, sometimes longer, of like hands-on time. And I always joke with my patients, I'm like, you're here, so like you're open to this treatment, obviously. I'm like, and the first time everybody gets pelvic floor work, they're like, kind of freaked out, I'm not really sure I should be doing this, it's kind of weird, but like, I'm like, I don't know where else to go, so they'll do it. And I always tell people, give me 3 visits, right, just to see if this is for you. And then the second visit, they're like, I think that kind of helped, I think it felt a little better afterwards, I'm not really sure, but yeah, I think this might be like actually helping. And then the third visit, they're like taking off their clothes, talking to you. They're like, oh my God, I told all my friends, and like, I didn't pee in my pants. I'm like, I don't want to watch you undress. So that's, and I tell them that. Like, I tell them that exactly, and it makes them laugh, and it lightens the mood, and, and it just kind of gives them like a little place to like in their own head navigate what they're doing. And because I'm a chiropractor too, right? Like not a lot of chiropractors do this work. We're licensed to do it. But that I think is also part of it for them. It's a job. If I was a GYN, or whatever. So I often explain too that we're going to palpate in an area that's going to reproduce their familiar pain and discomfort. And I want to know about that if that happens. And it's also really reassuring to the patient because it's like, they're like, well, what is that? I'm like, it's a trigger point. They're like, oh, that's that pain I have all the time. Like, yeah, it's a trigger point, or it's a group of muscles that's not working properly. And it feels really validating to them that A, it's not in their head, it's in the pelvis, and that, something can be done about it. And they feel like then they're doing something good for themselves and they're working on it. Be conscious of the draping and exam position, pull out a footrest instead of stirrups if that's all you have is a gyno table. You don't need them to slide down to the end of the table and spread their legs super wide. Just kind of, being aware and honoring that they're in a vulnerable position. And that, that this is also something totally new to them too. So, all right. So assessing pelvic muscle tone. This isn't my favorite diagram in the world, but this is sort of the best I could get. Gives you an idea. So first I tell them, I'm going to insert 1 or 2 fingers vaginally, and I just want to feel you squeeze your pelvic floor muscles. All right, I'm like, oh, you know what a Kegel is? They're like, oh yeah, I've been doing them all day, nothing's happening. Okay, good. You do a Kegel, right? So I just tell them, and I don't coach it, because I want to see what's their perception of a Kegel, of a pelvic floor muscle squeeze, and then like what's happening, okay? And you palpate. And what you want to feel, I think of the pelvis as if somebody's laying on their back, I kind of divide it up like a clock. So, if you're looking at somebody's pelvic floor, maybe pubic bone to the left hip is like 1 to 3, left hip to sacrum is 3 to 6, sacrum to right hip is 6 to 9, and then 9 to 12 again is from the right hip up to the pubic bone. Or some people will do like quadrants, right? The upper left quadrant, upper right quadrant. So what you want to feel for is what's happening. So my next slides actually. Okay, so what's going on? Are they firing? Are they firing at all? Sometimes they're like, I'm doing it. And I'm like, oh boy. Like nothing going on.
Yeah.
Sometimes though, what you want to feel for is there nothing going on because those muscles are already really tight and they're too tight and they don't have anywhere to go? Or are they so hypotonic that they just can't even like get together to even contract? Most commonly, what you will find is some are like, whoop, here we go, they turn on, and then there's like one section of the pelvis that's like, boom. And then they'll like turn on for a second and shut off. or it'll try to come up to tone and it can't, so it just poops out. And then there'll be like, 2 quadrants that are doing all right, or like all the front muscles, top muscles, pardon me, like between the hips, pubic bone and the other hip. Those will all come to tone nicely, but everything in the back is just like no tone. And then I think, okay, posterior muscles, I think more about like piriformis, coccygeus, what's going on, or what's going on in the front. And then I want to know, can they maintain the contraction and can they vary the intensity? So then that's when then I will say, now I want you to pretend like, peeing, you have to stop. And I don't tell people to practice their Kegels like that, but as a diagnostic tool, it's helpful. So, like, your 2-year-old just crawled into the dishwasher while you're in the bathroom. Like, you gotta go. You gotta stop peeing. And then they like, contract more. And then I'm like, okay, now the 2-year-old's like grabbed the knife out of the knife block and you're having a bowel movement, you really gotta stop. And I'm like, hold that, and then, because what I want to see is like, can they squeeze the muscles and like maintain that contraction? Can they vary it? Because some people, they can contract their pelvic floor muscles and sometimes they can contract all 4 quadrants, but they can't ever vary the intensity and they can't vary the duration of that contraction. So all those things tell me different info, which is like a whole nother class that I'm teaching this winter if anyone's interested. But those are all diagnostic clues that are really important. And this is why just telling mom, giving her good instructions on how to strengthen her pelvic floor muscles and send her home doing Kegels isn't always appropriate. Sometimes it is appropriate. Sometimes even like based on my first exam, I'm like, no, let's just like fine tune the Kegel, everything's firing. There's not a whole lot to work here. I think you just need some strengthening, and let's go over that. But a lot of times there's these weird patterns where half of the muscles are firing, half aren't at all. And all they've been given is help or Kegels, right? Well, I always use the analogy with my patients of it's like having an orchestra and it's out of tune, and you just tell them to practice more and more, like hoping that they'll sound better, right? It's never going to happen. You got to tune the orchestra and then have it practice, and then it improves.
That's a great analogy.
Yeah, people get that one. I like analogies. So internal palpation, I think using a confident touch with firm pressure is more reassuring to the patient. And I just kind of included that because I think especially a lot of us that do cranial work, we're really into the light touch. I think when you're doing pelvic floor work, that kind of firm pressure is more reassuring, and it depends on your patient and you, and and also more contact time. Like all people sit with their leg on, I'm sitting next to them on the table and they'll have their leg flopped out on mine, I'll have my other arm on their thigh, like that proprioceptive input to the nervous system of like more pressure is calming to people. It's like tummy time, like what Michelle was talking about, that calms us. And then again here, this is what I was describing about the positions. And then I feel for also, then I start palpating around after the Kegel. I start at the pubic bone on one side of the urethra. I always tell people this might make you feel like you have to pee, but you're not going to. Don't pee on me yet. And move towards the sacrum. And I'm feeling for, is there edema? So how do you tell if there's edema in the pelvic floor? What do you feel like you're pushing into? Is it water? Is it like a wet sponge? Is it like a dry sponge? Is it like, a barren, ropey desert? I mean, there's all different types of muscle tone that you'll feel. Is there contracture? So do you feel this area where there's just like nothing moving and it's all tight? Is there scarring in there? Do people who've had like hernia repairs, who have maybe like the titanium mesh prolapse surgery, sometimes they'll have some internal scarring that you'll be able to palpate. So just kind of feel that. And take note of it, because you'll see the edema will change as you do the work.
I just thought to ask you about the glove you're using. Are you using anything real thin?
I just use nitrile gloves. I don't use latex because someone will be allergic to it at some point. And no, just regular gloves. Yeah, that's a good question though. And then palpate the muscles. So then I go muscle by muscle and palpate each muscle for trigger points. Are they too tight? Are they not tight enough? What's going on with that muscle? And I do a lot of motion palpation. So I don't want to just feel that muscle statically. Great, it's tight. Can it move? Can it do its action in the pelvic floor? That to me is like the heart of this work. How does it move? How does it work for you? Treatment. Treat what you find with the tools that you have. So this varies for all of us, right? Some of us in our scope of practice, we can do ultrasound on those scars and all this other cool stuff. Other people, different tools, that's okay. So external techniques, skin rolling is so important with pelvic pain. Getting the fascia moving, getting the lymphatic system draining, so important. And I guess what I call skin rolling isn't necessarily like what we some of us may have learned in school, where you like lift it up and then move it. But just getting everything talking. Fascial release, trigger point therapy, nerve releases, like those moms that have like little nerve rootlets adhesed in their like C-section scars or their hysterectomies. You know, like work on those adhesions. Don't be afraid to like get in there and do it. And if you're not comfortable, send them to someone who is. Grafton, for those of you who knew Grafton, is really effective at scars. For those of you who don't know what I'm talking about, it's a set of stainless steel tools that do really deep myofascial release work, and you can really get in there and mobilize the scar. Grafton technique, gua sha is something like with those of you who are an acupuncture background, it's similar, but it's really, really great at getting scars moving. But that's not always appropriate for every patient. You know, for some people, that really gentle fascial release is more appropriate. But for somebody who's like, you know, they're going to do what they're going to do no matter what, and they need to feel better soon, and they're healthy, and they're like metabolically healthy, the Grafton work is really effective. It creates kind of what we call a healing crisis. So it really like it breaks the tissue up. I mean, they'll turn black and blue. And then your body comes in, kind of cleans it up, and it basically reminds your body like, hey, this area is not done healing. We have all this collagen cross-linking, kind of a mess here, and now we've broken up all the unimportant fibers, and you know, we want our body to come in and clean that up. So that's what the Grafton does. I do a lot of that in my practice. So the internal techniques, it's kind of the same as what you do outside. Like there's no magic. So pinning and stretching the tight muscle. You know, post-isometric relaxation. Okay, I'm going to hold your leg out here. I'm going to put my hand on the top of your thigh. I want you to push into my hand. Good. Now I want you to relax into the leg thigh, come out a little further. You know, it's really like, it's not special. It's not magical. It's just applying these tools that we all have to do part of the body. That's all. Range of motion exercises. I do some crazy stretches with people, and I don't bust them out on the first visit. You know, it's like, I'm going to have my hand in your vagina, I'm going to wrap your arm over, like your leg around your head, you know, we're going to stretch that psoas. And then, like, you know, if you did that on the first visit, people probably wouldn't come back. But, you know, when people know you and you're like, I got something for you, they're like, oh, thank God someone's doing this. That's what people usually say. You know, they're like, thank God someone's finally working on this. Internal myofascial release, soft tissue mobilization, connective tissue mobilization. I put biofeedback in there because, you know, sometimes just bringing awareness to that area is helpful. You know, it doesn't have to be like with machines and tools, but just kind of saying, hey, do you see when you take a deep breath in and like when you breathe out, that muscle will relax, and you know, I want you to like move your hip into my hand, but do you see how you're just using the other side of your pelvis to do that? I don't want you to do that. Move your actual head, that type of stuff. When patients have met their treatment goals, make sure you send them to physical therapy so that they can learn how to strengthen their muscles and move correctly, right? I think that's a big problem for these women who are like, I had pelvic floor work and it didn't work. So what I always explain is like, I'm going to take the duct tape off, and then you have to learn how to move again. You have to learn how to be strong again. And I just don't have time in my practice. Like that fascinates me, that whole world. I don't have time to do it. And that's not what I'm good at. You know, I'm still figuring out what I'm good at. But, you know, it's like, do what you're good at. And so I tell them, I've taken all the duct tape off. You've got the super nice, you've got the balanced pelvis. Your SI joints are moving great. This is terrific, but you've been walking around for 5 years like this, right? You can't just like fix it and then expect somebody to automatically then recorrect all those patterns. And the body really like, I think a lot of times with our bodies, you give us a nudge in the right direction. Our bodies are like, oh, thank you. But I think it's really, really, really helpful to send them to a therapist or a good Pilates instructor or a good yoga instructor, somebody who understands the strengthening, balancing, how to activate transverse abdominal muscles. I think just telling them then like, you know, maybe you've worked with somebody for like 3 months, like these really hard cases, and then I just think like teaching them how to do a Kegel and sending them out the door is like so inappropriate because they've worked for so hard to get help for themselves. You gotta ice the cake, you know, finish it off. So I'd like make them go to PT. And if they like come back to my office 6 weeks later, I'm like, you weren't in PT with me. They're like, no, I was too busy, I felt so good. And I'm like, I know, like it'll keep coming, you know, you gotta like fix it though. Most commonly, pelvic floor work is done by physical therapists, and there's like a really interesting move within that community. There's like PTs who do more myofascial based work, which is kind of what this lecture is about, and then there's PTs who are trained to just kind of do like biofeedback, dilators, you know, so it's a very different, like, when you meet a physical therapist who's like, oh, I do pelvic floor work too, I'm like, awesome, because we all need to do more of it, but sit down and like ask people what they do, how they do it, and you know, and I don't think there's any right or wrong, but I think you as a provider, if you're making referrals, just need to be educated. And then, you know, a lot of us are licensed to do it. I'd love to see more nurses, GYNs, midwives. You know, for people who are already doing pelvic exams, like midwives, when you're in there, just say, I'm going to take a second and palpate your muscles. And it's like, and I've taught midwives before, and it's like this whole different, like, round to, like, not just feel the vaginal wall, but for the cervix, to, like, feel through it. You know, and like, I don't even think about the vaginal wall. I'm just like, that's just like my way that I get into the muscles. You know, and so just to kind of like tune your hands in to what else is in there. And then just a note to LNTs, I think that LNTs are actually super well suited to do this work. I think it would be great if we all did it, but I really encourage you to like work with somebody who's licensed to diagnose, because, and I'm just saying this from my own personal clinical opinion, there are so many cofactors. It's never, you know, it's rarely ever just musculoskeletal. So just, I would encourage you, if this is really something you're excited about, find somebody who's just really open to working with you, who that you, like a GYN or a naturopath, you know, that you can say, hey, I want you to go get a well woman exam. I just, you know, I need you to come back with a clean bill of health, and then we'll work on the muscles. You know, and that way you kind of know that you're moving forward. And if somebody's not getting better, you know, you kind of then know the next step, and, you know, you want to make sure that they're not like in the middle of an autoimmune flare, and you're just hoping you can fix the pain with the muscles, because that's not going to happen. So, you know, it just kind of know and work with other people. I think we all need to work with people. And, you know, just really respecting the fact that by the time women seek out this care, they're really hurting a lot. They've been to a lot of different people. So what I always tell them is, give me 3 visits to make up your mind. You know, and if you don't think that this is helping, I'm like, I'm going to tell you how I think you're doing, but like your vote is, you know, just as important, if not more important than mine. And if it's not helping, I will help you find somebody else. You know, I will refer somebody to somebody else who does pelvic floor work. You know, if I still think it's truly a muscular problem, maybe I'm just like, my tools aren't getting it. You know, and so don't be afraid to refer, and don't be afraid to like, because you're already going to be plugged into this awesome resource group, don't be afraid to help them find the next step. And people are really grateful for that, and it's a really nice way to build that trust with your patients. So tips, believe them. It's complicated, often many layers, crazy stories, right? I mean, you'll just hear the most wild things that people will tell you, and it's just fascinating to me. And don't rush the history. Watch out for the pauses, right? No. Or like, you know, do you have pain with intercourse? And they're like, no. Do you have discomfort? Yes. Kind of, maybe sometimes. Well, what does that mean for you? You know, let's talk about it. And you know, tease it away. Or not really. You know, do you ever like, you know, sneeze and then leak a little urine? Not really. What's not really? Well, it only happens like once a day. You know, so it's like that perception out of that. What's going on? Again, this next one is like a topic for a whole other seminar. Learn about central sensitization, because these women are so chronic, right? This is how our nervous system works. After 6 months, pain is centrally sensitized, and I'm giving like a really, like, this is like a basic explanation of what this process is. But basically, you know, it's an old part of our brain that remembers if something's been hurting for a while to help us not keep hurting it, right? If every time we stuck our hand in the fire when we didn't remember we got burned, it'd be bad. So it's evolutionarily makes sense, but when somebody's had pain in a part of their body for so long, even once what's causing that pain will be gone, they will still have that pain there, they will still feel that pain. And so what I tell people is, you know, you need to spend some time talking to them about this, because I'm like, okay, you're going to start working out, and you're going to feel like all your old pelvic pain is back, but sometimes it's just their tight muscles and the good, sore, happy muscles, because like you exercise them. But your brain takes any input, or output from that area of your body and just goes right back to first, old familiar pain, old familiar pain, old familiar pain. And so educate yourself about it, or send them to somebody who can kind of educate them about it. Because I think that's like a big roadblock too as to why people get frustrated. And then don't be afraid to advocate for them. Don't be afraid to refer if you're not helping them. And then, I think a preemptive strike is always best. I talk to women, I would love to talk to everybody about this when they're pregnant. It's like we were talking with the lactation, talk to them before they need your help. And I don't put any time frame on it. I'm like, yeah, having issues? You can come back after the baby. And they're like, how soon? Those the total type A moms that have read every birth book and they have a 6-page birth plan. And I'm like, whenever, just you'll know. And but I think that if we can just plant that seed, hey, even if in 2 years you're having any pelvic floor issues, just call me. I'll help you figure out what to do about it. Yes, Kirsten.
How soon postpartum do you like to see people? Is it really, do you have a preference?
Yeah, that's a great question. So I always tell the moms, first, just as long as they've been kind of cleared by their provider, so especially a mom that has a lot of lacerations and tearing, I just want to make sure there's good tissue integrity before I'm sticking my hands near an open wound. So, set of 6 to 8 weeks. That's kind of my window. And then I would say that usually what I'll tell moms is just kind of whatever they would physically be ready for intercourse, not necessarily mentally or emotionally, but just physically could tolerate something in their vagina, that's what we're doing, right? Sort of with our hands. So, I kind of use that as a guide, and I just say, whenever you feel ready. But 6 to 8 weeks, unless something has happened, if they think mom's fractured her tailbone during birth, and there is no tearing, and there's no contraindication, then I will work on them sooner and talk to their provider. Yeah.
Can you talk a little bit about the urinary incontinence from the musculoskeletal? What's usually the cause of that? That seems to be one of the most common things.
I know, as I was putting this together, I was like, I should really, that's a whole other lecture topic almost.
This
But
particular muscle?
it's usually a laxity of part of the levator group, so kind of the big group that goes from front to back, and the fibers of obturator and turnus. And sometimes it's a laxity, sometimes they're really hypertonic all the time. So that's why I didn't go into it too much, because there's really a bunch of different presentations. So, but usually what I find is it boils down to not enough tone or too much tone. And then, yeah, the obturator is almost always the culprit. But the thing is, and this is why I think it's so tricky, right around the urethra, fascially, we have so much going on, right? We've got the pubic symphysis, we have all these muscles inserting, you've got your adductor muscles. I mean, it's we have, I think more than anything, it's this fascial, this central junction spot where all these things are inserting and coming off from, and there's all this fascia, and it's just kind of this area where the poor urethra is just trying to do its thing, and it gets tugged in all these different directions. So I don't know if that can answer your questions.
And then just as far as getting trained to do this work, who's teaching?
So
Experience.
I know Tammy Kent is teaching. I haven't taken her class, so I know a lot of people who have and have really enjoyed it. She's teaching this work. I know that within people's own professional worlds, these classes are being offered. So if you're a physical therapist, the APTA teaches classes. I'm teaching a class because I work in the gorge and I'm sick of my patients driving an hour to see me, and I want more people doing it in Portland. So I'll be teaching a class over this winter, probably end of January or February, with Heidi Peterson, who's the GYN professor at the naturopathic school. So it's going to be a weekend course of all the stuff that I talked about. She's teaching kind of about all the causes and the etiology and the pathology, and then I'm going to be teaching a practical, workshop. We're going to have the GYN models there, because I think it's too hard. The first class I took, we did a lecture and then practiced on one another, but it's really hard to try to get all this information and then then be the model, and so I think that's kind of the best way to learn.
So you have surrogates, is that what you're saying?
Yeah.
That's awesome.
It is awesome. I'm really excited about it. So that should be a good class. So I just need to get my act together to finalize the times. Yes.
Do you find that women who get this pelvic floor work done during pregnancy are less prone to tears and?
I do.
Okay.
I do, because what I think about is, but I think it's pelvic floor work, but I also think it's like manipulation and structural work here to evening their pelvis, right? That's like, I think it's secondary to this like rotation that they'll get going on, and then they're trying to push a baby through these, it's like, this like twisted fascia and muscle. And so, but yeah, I do think it's really important during pregnancy, and I do think it can really help. But I've had moms come in at like 40 weeks with their provider, and the provider's like, feel how their cervix is like over here, and the baby's head just like can't get down there, and can you like do some work to move the cervix, and that's pretty cool. So yeah, I think it's really helpful.
Okay, so I have a client who supposedly has this phenomenon called, what is it, PAG?
PAG.
Where the nerve that it overexcites the clitoris and they are constantly craving sex. What do you know about that?
I don't know anything about that.
Do you think that this is actually a pelvic floor issue?
I think a lot of times, a lot of that nerve stuff is related. And usually what I tell people, because I have people come in with like, honestly, like these weird diagnoses. They're like, they've been to the Mayo Clinic and they're like, I think I have like torn cysts on my sacrum. What do you know about those? What can you do? I'm like, I don't know. I heard about it. But I do think that I can confidently tell those people, anytime you're having this somatic dysfunction in your pelvis, that of course there's going to be a musculoskeletal component. Usually what I tell them is I can't tell you how big of a factor that is, but I can confidently tell you if we do a couple sessions, I can tell you how big of a factor from an educated guess I think it is. And then, we can do that work, and the exciting part is finding out how much was that factor a part of the original etiology. And that's kind of usually what I tell these people with just those things where you're like, I don't know, but I would imagine that like muscle spasm, nerve root-led adhesions, fascial restrictions, could impede blood flow to the clitoral area, could, impede nerve flow, could cause this hyperexcitable state because of different firing patterns in the pelvis. Yeah, I could definitely see from a musculoskeletal standpoint how that could be related. So.
Do you think this helps with like hemorrhoids and stuff?
Yeah, the hard part with hemorrhoids is that they're usually so tender that usually people are like you can't really touch the area because it's just too inflamed. Kind of usually after, and I work with somebody who does really great hemorrhoid work. It's about that team approach. It's really great though with vaginal varicosities, even during pregnancy, or the moms that have like an inguinal hernia and vaginal varicosities. Or they call me and they're like, I just had my baby and I've got a third labia. Oh my God, they're freaked out.
See, I like when I see those, I'm like, please don't let them tear near that.
Yeah. So it's really good. It's really good at reducing that edema, but it's very especially when someone's pregnant. Well, every time you do the work, it'll take like a little layer off, but it's gonna come back. Or like if it's the mom who's like held in on working until she has the baby in the office. It's going to come back. But, I'll tell them, you can come in labor and we'll do this work,
Awesome.
and that is helpful.
Do you ever do on-call care?
I don't. I have a kid now. I used to do, honestly, I used to do on-call work, and what I would find would happen is that people would call me as a last-ditch effort.
Yeah.
They would call me when it was heading south, and here's a mom I don't know.
Yeah.
She's in labor. She's at that point probably kind of either panicking or close to panicking, and so are the providers. And I don't feel like I can really get informed consent, and I feel like I don't want to be that person who's like, can I do anything, and then what are we going to do? So I didn't like the situations that, I ended up in. If it's a patient who I know, who I've worked with, I'll go to your birth, totally. I'll show up. So that's kind of what I tell people. So, and then summary, emphasize the team approach. Stress that these things can take a long time to resolve. So just avoid setting unrealistic expectations. Somebody who's on morphine, gabapentin, antidepressants, who's had pelvic pain for years, I'm like, let's look at this in months. My goal is after a month to have you walk around the block pain-free. This could take 6 months, and I just tell them that. Or I tell them too with less complicated things like Michelle was saying, I had a couple visits to Hedgeroy Vets, but let's see where you are in 6 to 8 visits. And usually with pelvic pain, I find in 6 to 8, with 3 visits, they know if they're on the right road or not. Usually they are. With 6 to 8 visits, they see the light at the end of the tunnel. And that light's still pretty far away, but they at least know that they're like getting better. And then educate patients in their own terms, break it down for them. Really good, obtaining really good informed consent. What I tell people too is procedures. I'm like, you've had everything else done to you. Alternatives, you're living them, right? You're on the drugs, you're on the morphine. Oh yeah, go ahead.
If you're across the country,
Mhm.
how do you find out about even finding somebody who does
There's
this?
people, and I have some resources actually at the end that have really great links on their own web pages, and you
Thank
just
you.
got to dig. And you got to be able to say, can I just come talk to you about what you do, and ask them. But I tell people, alternatives. You kind of, most of the time, like from my office, like people have done everything else. I'm like, well, you tried PT and you had surgery, and so I'm kind of it, like let's give it a shot, or I'll say, you haven't done this and this also, so let's keep that on the radar. Maybe that'll be more appropriate for you. And then I tell them in terms of like what's going to happen. I say afterwards, you're going to maybe sore, but it's not sore like my vagina hurts. I usually tell people as you're stepping onto the curb or getting into the car, you're suddenly using muscles that haven't been working in a while. So it's kind of like an achy, like, whoa, this feels totally different. The most common thing that people tell me is that they feel like they have a new foundation, they have a platform, which I think is really cool. And that's usually what I tell them. This is what patients tell me. They feel like they have a new platform, and they have a foundation and a base again, which I think is really grounding physically and mentally. And then you always tell people, if it gets worse, I want to know about it. Like call me. If you feel horrible afterwards, I want to hear about it. And then just educate. So that's it. More resources. So we're talking about some great books. These are all in the handouts. Tammy, I know she teaches as well, the International Pelvic Pain Society. Jerome Weiss, if you really want to geek out and like learn about the neurologic mechanisms of pain generators and chronicity, this article will like put you to sleep. But Jerome's pretty amazing. He has some good stuff on there. And thank you to my family, my teachers like Carol, and my patients, my biggest teachers. And then here's my email. So if you want to get put on the list for the class, send me an email. And that's it. Thank you. I don't know, it's up to it.
You have time, you have
One
time
more
till
question?
11.
Oh, okay.
Great, I'm just wondering about doing visceral work with pregnant women, if that's like a do it and follow on with it.
I do visceral work. It just gets kind of like hard to work with the baby in there, so I'd say I do more like fascial work on them and like more muscle elongation and strengthening than a lot of the deeper visceral work. But yeah, it's not contraindicated.
But definitely afterward.
After so, yeah, for sure. So, any other questions?
Oh, wait, there's something.
I have a sign.
Oh, sorry. I'm sorry. Oh, go ahead.
Any impact of IUDs on the pelvic floor?
Yes. And again, that's where like I tell people, hey, when's the last time you saw your GYN? Oh, I don't know, like 3 years ago when I got the IUD put in. Go back to them. I need them to do an ultrasound of your uterus to make sure it's not like poking through one of the balls, right? Or, that it's not in a malpositioned place, things like that. So yeah, that's a good question.
Do you give your patients any exercises? The pelvic floor stuff?
I send them to PT. I have some awesome PTs out in the ward, and so I like to start that relationship because I tend to find that if I start giving them exercises, I'm like, well, why can't I just come back to you? And that's not my I'm really interested in it, but I'm not the best person for that. So.
Yeah, I want to say that I'm just so grateful to you for doing this work and getting it out there, and I have a thought about endometriosis, about how this work can't cure it, but I think that the earlier we can get to women at younger and younger ages and have this work be more acceptable, I think we can do a lot about endometriosis in terms of reducing torsions in the uterus that end up causing the endometrial tissue to be regurgitated into the abdomen. And
Completely.
yeah, I mean, once it's there, it's hard to you can't really get rid of it unless you grab it and surgically, but we can prevent it.
It's really effective. I have a lot of people with endometriosis or kind of early endometriosis in the pelvic floor where they can either go off their meds sometimes they're able to manage it.
Yeah.
So.
Speaking of autoimmune disorders, my experience with autoimmune and craniosacral is that sometimes if I dip more into a more manual approach, like you were talking about your treatments are with this, that sometimes their pain levels, just because they have an autoimmune disease, their just overall pain level picks up.
Yes.
And I'm curious about how you deal with that, because it seems like a lot of these pelvic floor issues are related to autoimmune.
They are.
So how do you deal with that?
So I used to work with naturopaths, and I'd say like, hey, I think that you have an autoimmune issue, and I think it's not really under control. And if you can just turn down that immune response by half, I don't have to do as much work. So sometimes I'll have people work with a naturopath for like 3 months before I'll see them. And now, like where I am now, I haven't found somebody to work with, so I'm like, I'm just gonna do it. So I'll work with them on diet modification, running labs to find out like what are you really attacking. Super interesting that the autoimmune world is like on fire right now. That, like we're finding that people are making antibodies to their smooth muscle tissue. And they're like, oh, hey, guess what? Like 90% of women with interstitial cystitis have these antibodies against their smooth muscle tissue. What lines the bladder? Smooth muscle tissue, right? Like it all goes together, and we can't fix autoimmunity. And I'm not against like, more like immunosuppressive therapy, because people are losing function, right, when there are these huge flares. But there's a lot that you can do with diet, lifestyle, supplements to like try to put out the fire, and a lot of it's education. But yeah, I'll work with them on that first. I'll just tell them, we can get started on the pelvic pain, but you're going to be really frustrated. It's probably going to get worse, until you do this other stuff. And they'll come back, because they want to get better.
So you back off of the manual therapy before?
I do, because you don't really get anywhere. You're totally right. You make them worse, or it's just like 1 step forward, 2 steps back. So, yeah. Anybody else? Questions? All right. Thank you very much.